Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, good evening for everyone that they are listening to us now. This is a Middle East Ophthalmology meeting, and we are doing maybe the last meeting of this year in 2020. That's why we call this meeting MIOM 2020 recap. So I hope that you enjoy our all meetings that we have done through the year 2020, and we have done more than, I think, more than 40, around 40 meetings during this year. In addition to also to the MIOM Middle East Ophthalmology Conference, which done in 3 days virtually. 2020 is not a bad year as we think. It's have a good things we have to remember about it, that we are exposed to many friends, we get in contact with many, and we learn how can we appreciate what we have in our hands before and looking for future in another way. So the first, today we will have our 2 sessions. The first one is a posterior segment, and the second one, it will be about anterior segment. First speaker for us today, our guest speakers, Dr. Laurent, and he is former president of the French Society of Ophthalmology. He is a professor of ophthalmology, official level exceptional cases, and chair of the University of Lyon, France, and associated chair of the Department of Ophthalmology, Croix Rosy Teaching Hospital, Lyon, France. Dr. Lyon, he will give us now his presentation. Please, Dr. Lyon, the mic with you.
Thank you very much. I will share my screen.
Please.
Okay. So we reduce the screen. Okay. So thank you very much for this very kind introduction. I'm very happy to be with you today. And so I'm going to speak about the pharmacological management of diabetic macular edema. And in this management, I'm going to speak about the place of fluocinolone implant, that is to say, Illuvien, in other words. You can see here my financial disclosures. You can see Alimera, but also Allergan, Bayer, Novartis, and I consider, I like to say that there is a sort of neutralization, in fact. In medicine, we have 2 types of studies. We have the randomized controlled trials, the interventional studies, and the observational real-life studies. And you are going to see that we need both. For the RCTs, with the RCTs, they are the gold standard for a drug to obtain a label. But there are bias because patients are selected with strict inclusion criteria and strict exclusion criteria. For example, there are no patient included with high baseline visual acuity or low baseline visual acuity or prior treatment or comorbidities. And secondly, the second bias is that this population included in these RCTs are very motivated. For example, in the diabetic macular edema trials, RISE, RIDE, VIVID, VISTA, the patients accepted to receive monthly anti-VEGF during 36 months. It's a long time, 36 months. So these patients do not necessarily look like our daily patients. And it's not easy to reproduce these treatment regimens on a daily basis, and definitely because there are not enough injections with anti-VEGF in real life. And unfortunately, we know that life is not a long, quiet river. And this year with COVID-19, we know that. So physicians also need to analyze observational real-life studies. And for why? To check the efficiency of treatment in real conditions. But of course, there are also bias with these studies. Missing data, loss of follow-up, and the level of evidence is lower with these studies. Therefore, it's important not to have only 1 or 2 real-life studies, but several real-life studies in order to draw valid conclusions. And I'm convinced that if many real-life studies go in the same way, if different teams in the world all found the same conclusions, we could assume that this direction is right. So it's very important to analyze not only one or two real-life studies, but different real-life studies. And that's why I just made a literature review about Iluvien to assess efficacy and safety of Iluvien fluocinolone acetonide implant in DME observational real-life studies. And I found not one or two, I found 22 observational studies with at least 6 months of follow-up and at least 10 patients included. And I found so it represents almost 2,000 eyes of 1,700 DME patients. So the different outcomes, like you can see, is visual acuity evolution, peak visual acuity gain according to baseline visual acuity and DME duration, the thickness, correlation between visual acuity and anatomical dryness, percentage of additional treatments, and time before initiation of them according to DME duration, and different criteria about safety. And you can see on this slide, the 22 articles I reviewed, and I'm going to present to you today now the results of this review. If we look at the baseline characteristics, the mean DME duration was 3.2 years. It's a really long time, 3.2 years. And we could imagine and expect that with a shorter DME duration, we could have better outcomes. Phakic patients represented 19% of this cohort. Patients with at baseline hypertension, 1/4. So it's very important because in real life you had patients with hypertension, baseline hypertension, not in the pivotal randomized controlled trials. And the mean visual acuity at baseline was 61 letters, and the mean thickness 500. If you look at the visual acuity gain we obtained, on the horizontal axis, you have the baseline visual acuity. On the vertical axis, you have the peak visual acuity gain. And each point, each blue point, corresponds to one article. And so you can see easily that the gain with Iluvien is very good. And like you can see, 86% of these studies, the 22 studies, had a peak visual acuity gain more than 5 letters. And so at baseline, it was 51 letters. And you can see that at the peak, the final visual acuity was 59.5 letters. So the mean peak visual acuity gain was plus 8.7 letters, with a follow-up of almost 1 year, 11.3 months. Now, another way to present the same results, each column corresponds to one article, and the blue part corresponds to the baseline visual acuity, the orange, the visual acuity gain, and so the addition, the final column, corresponds to the final visual acuity. And so again, you can see that we have, every time we gain vision with Iluvien, and in the majority, we gain really good visual acuity gain. And so the peak, again, of the visual acuity gain was plus 8.7 letters. Very good results. On this graph, you can see on the horizontal axis, the baseline visual acuity, on the vertical axis, the visual acuity gain. And so you can see that we had always an improvement in visual acuity in the 22 articles. Now, if you look at the impact of baseline visual acuity according to different levels, less than 50 letters, 50 to 60, or more than 60 letters, and if you look at the influence of the DME duration, you can see that we had better functional improvement for DME patients with low baseline visual acuity, less than 50 letters. This is logical, but you can see that even for the good visual acuity at baseline, more than 60 letters, the mean peak visual acuity gain was plus 7 letters. It's very good. They are very good results. And about DME duration, we have better functional improvement with DME duration less than 2 years, or between 2 to 4 years. About visual acuity, I think you have already understood the good results. So the mean peak visual acuity gain was plus 8.7 letters, with a mean final visual acuity gain of plus 6.9 letters. Mean time before peak, 11.3 months, but the mean final follow-up was 20 months. Now about the anatomical outcomes, you can see that for in all these studies, every time we had a decrease in the thickening of the retina, and so at baseline it was more than 500 microns, and you can see that we could reduce until 332 microns. That is to say, a reduction of more than 20%. You know this threshold of 20% for the DCRNet study group, American study group, saying that if you reduce your thickness more than 20%, you are an anatomical responder. And you see, you know the definition for functional responder, again, more than 5 letters. So here, the reduction is not 20%, it's 34.3%. So very good. And this spike of reduction was obtained in 16 months. Here you can see the results according to different level of baseline CRT. And retinal thickness improvement with Illuvien was obtained regardless of baseline CRT, very important. But more important is the CRT at baseline, better will be the anatomical improvement, very logical. And here you can see what I said before in the table. And now this graph is very interesting because I put on the horizontal axis the thickness and not the thickness, I'm sorry, the thickness decrease in percentage. And so the vertical red line at 20%, on the right part on this vertical line, you have all the anatomical responders. And so you can see that in the 22 articles, 17 are anatomical responders. And now, if you look at the vertical axis, the peak visual acuity gain, we have an horizontal red line at 5 letters. And so all the points, all the articles up at the up of this red line are functional responders. So now you can see that more than 3/4 of these studies of the patients, of the eyes, presented both anatomical and functional improvements post-Illuvien injection. Very important. And 11.1% presented visual acuity gain significant with less than 20% of thickness decrease. Now, very interesting about the additional treatments. We can see that 30% of additional treatments are needed and initiated 15 months post-Illuvien, and time before initiation seems inversely proportional to DME duration. So it's always better to treat early the patients. About safety, you remember that at baseline, hypertension was present for 1/4 of these eyes. Hypertension post-Illuvien was present only for 20% because there was additional treatment, additional IOP lowering treatments. And you can see that only less than 1/4 of these patients, of all the patients treated, so you remember almost 2,000 eyes, 2,000 eyes. So less than 1/4 needed IOP lowering treatment. If you look at the rate of IOP lowering surgery, it's low. It's very reassuring for us, the physicians, 0.6% only. And of course, we had the patients needed to have cataract surgery, of course. So hypertension was well managed by IOP lowering drops. We had less IOP lowering surgery in real life versus the RCT FAME. And of course, lens opacification and cataract surgery was observed during the first year post-injection. And on this table, I put the FAME study and one of 5 of the 22, and these 5 studies are very important. That's why I put these 5. But you can see in all these studies that the rate in real life is lower. The rate of IOP lowering needed or IOP lowering surgery is lower in real life in comparison to FAME. So the conclusion of this analysis of the 22 papers is that real-life functional and anatomical results of ILUVIEN seem comparable or even superior to those of RCTs. Used in second or third position in therapeutic strategy, phac implant allows an improvement of treatment burden. Functional visual acuity gains are equal or even superior to others' DME treatment in real-life studies. Good patient profile selection, early DME, seems important in visual acuity gain and treatment burden improvement. And we have a safer profile of phac implant in real-life studies. And this is permitted thanks a good patient selection without hypertension with prior steroid treatments. So now I have 8 remaining minutes to finish my 20 minutes of talk. And I would like to present to you the algorithm I'm using with ILUVIEN. To understand this algorithm, I think it's very important to understand the pharmacokinetics data we have with Ozurdex, the dexamethasone implant, and with phac implant with ILUVIEN. In dark blue, you have the Ozurdex, and you can see that the concentration is very, very important with Ozurdex, but will decrease very rapidly after the first 3 months. With ILUVIEN, the concentration at the beginning will be really lower than with Ozurdex, but it will be maintained during 3 years. Very important to understand. So if you want to treat a very important relapse of DME, there is a risk to ILUVIEN to be not sufficient. And so I think that for these patients with a very important relapse, probably it's more logical, it's more strategic to inject an Ozurdex and 1 or few weeks later an ILUVIEN. With Ozurdex, you will decrease rapidly the macular edema, and thanks to the ILUVIEN, you will maintain this, you will prevent a new relapse during few months, many months, 2 to 3 years. So this is the algorithm I propose to you. So this is for center-involved DME, of course, with visual acuity impairment, with a response deemed insufficient with available treatment after optimum control of systemic factors. If you began with an anti-VEGF, you have bad responders or injections burden, and so you will try Ozurdex in second line, or you can use Ozurdex in first line. We have to check the absence of hypertension with at least 1 or 2 Ozurdex before using ILUVIEN. This is really more prudent. And so we will have 3 different situations. Good responder with Ozurdex, an interval between 2 injections acceptable for the patient and the doctor. And so we can go on with Ozurdex. Or we have good responder, but the interval between 2 injections is not acceptable for the patient and or the doctor. Or we have bad responder with Ozurdex. If we have good responder, of course, we are going to use ILUVIEN. And ILUVIEN's goal for this good responder with an interval not acceptable is to reduce the therapeutic burden and prevent DME recurrence. And we have 2 ways, 2 solutions. Either you can inject ILUVIEN alone, but not if it's a truly significant anatomical relapse. So either we can inject ILUVIEN alone, and if not enough at 1 month, we complete with 1 Ozurdex. Either we inject 1 Ozurdex, followed 1 or 4 weeks later by ILUVIEN. And don't forget that a monitoring visit is mandatory every 3 months post-injection. Or we have bad responder to Ozurdex. We have to switch to anti-VEGF monotherapy if it has been never tested before, of course. We have to perform an angiography to check, for example, for macroaneurysms that can be treated by focal laser. We have to check if systemic risk factors are controlled. And if everything is okay, either we can use ILUVIEN, either we can use a combo, either we can perform a vitrectomy with a peeling. And now we are going to check and to monitor our patient. And if there is a relapse, if there is no relapse, we consider monitoring only every 3 months. I already said it to you. If there is a relapse before 2 years, we can consider an angiography. We have to evaluate systemic risk factors, and then if there is no additional need, we have to use what is called rescue or additional treatment. If there is a relapse after 2 years of Iluvien injection, we have to consider a second Iluvien injection. And in case of a planned incident like cataract surgery, for example, it's not mandatory, but do not hesitate or ask to yourself, discuss, think about that, to inject preventively and systematically an Ozurdex or anti-VEGF injections without waiting for a relapse, in addition to this Iluvien already present in the eye. This is my algorithm. I have 3 additional minutes, so maybe I can show to you very rapidly 2 case reports. This one is a female, type 2 diabetic for 30 years. In the left eye, I want to show to you the left eye. She had 6 Ozurdex between June 17 and September 19. Then 2 Lucentis because there was a Ozurdex rupture in France and in the world. And then we continue with Ozurdex. And we discuss about Iluvien because there was a relapse at month 3 with Ozurdex. Every 3 months, we needed an Ozurdex, and Lucentis was inefficient, not efficient. So there was a real burden for the patient. And we decided to inject Iluvien alone without an Ozurdex, without additional treatment. And here you have the results. At month 3 with Ozurdex, and we injected only Iluvien, and you see M2, M6, M12, M16, M19 with a perfect vision 20/20, with no hypertension and with no need for an additional treatment. And the last case report is a man with diabetes, but also it was referred for a nuveopapillitis or a diabetic macular edema. They didn't know. We found no diabetic retinopathy at the fundus and the vitritis, and of course we found also a papillitis. So only the right eye was affected, so it was a severe CME plus papillitis. No help with the angiography. We perform vitrectomy and peeling, and we also look for lymphoma with interleukin 10 and interleukin 6. The uveitis assessment was negative, and we decided to inject an Ozurdex. We needed to inject 12 Ozurdex with a very good results, but and we had also an hypertension very well tolerated with dual hypotensive therapy, and we have a relapse every 4 months. And the patient, it was a burden for the patient, and he wanted a longer duration drug. And so we discussed Iluvien, and I performed 1 Ozurdex, followed 1 week later with 1 Iluvien. And here you have the M4 Ozurdex relapse. Then M2, it was efficient. You see M5 because the M4 visit was shifted due to COVID-19. And so at M5, we re-inject Ozurdex, and 1 week later the Iluvien. And you can see the results at M4 of Ozurdex with no relapse for the first time at M4, with no hypertension. You see the IOP 9 millimeter until dual therapy. To conclude, my take-home message is: many inflammatory mediators are involved in DME. 1/3 of non-responders of these patients are non-responders to anti-VEGF, and that it does not decrease even if you continue to inject anti-VEGF. So we need steroids. Iluvien had a good efficacy in RCT and real-life studies. We reproduce the same outcomes in the real-life studies on the stabilization of visual acuity, and it was even better if the baseline visual acuity was high. Anatomical and functional efficacy was found in real life, close to the results of Ozurdex. And we have a tendency to obtain better functional results in the group of newer DME and reduction in the frequency of associated treatments. About safety, we have no disaster at the cost of a quarterly visit. Majority of patients with hypertension are controlled with topical treatment. Very important to remember. We have better outcomes in real life, 0.3 to 1.3 of filtering surgery in large series versus 5% in FAME, despite the fact that glaucomatous patients were included in the large observational series. And in patients with hypertension, without hypertension history and without pressure, even despite prior treatment with Ozurdex, the risk of hypertension is extremely low. So there is a rule of 3. 1 patient in 3 requires additional treatment. About 1 in 3 patients requires hypotenizing treatment, and monitoring of patients every 3 months to check safety and efficacy. Thank you for your attention.
Thank you very much, Dr. Lawrence. This very excellent presentation. And we have about 5 minutes. We can have questions and discussions. First of all, my question to you, you mentioned a point about the study, randomized real and different between randomized trial study and the real life experience. And you are thinking better to look for the real life, which is the one is better. And can you just clarify why you think is real life is better? In what way? In a very short, please.
Yes. When I said it's better, I wanted to say about the results are better in real life in comparison to film. Why? Because the patients are different, and I think it's very important to look at the real life studies, because the patients we treat in real life looks like this patient in real life studies. So if you want to have good answers to your patient with prior treatment, with comorbidities, with a low baseline visuality at baseline, you will need to look at these real life studies and not only at the on the RCTs. This is my message.
Yeah, the real life you mean study, it will really express what is we are facing in the real life. And this is completely different when we are selecting a patient according what you have mentioned. There is an exclusion and inclusion criteria that makes something different. And we face this one not only, I think, in Illuvian, but also in many other studies. So the real life is completely different. And we found, especially if we think about the intraocular pressure complication that everybody is afraid about when we are using steroids, especially Illuvian, they are for a long period of time. And the surgery, was in the film, it was 5%, but in real life, it became very less. Can you just highlight this point also in a comment about the complication that most of the people or the doctors, they are thinking it is something that we have to be afraid of?
I think we have less hypertension complications in real life studies, despite the fact that 1/4 of the patients included at baseline had already hypertension, because these patients were selected. That is, I mean that these patients were already controlled. This 1/4 with hypertension at baseline were perfectly controlled with hypotensive drug. And in the big majority of these patients in these studies, they were controlled with a monotherapy only. So patients with a dual therapy or triple therapy were not included in the real life studies. And secondly, I wanted to add something. Yes, is the fact that it's very important not treat with Iluvien a patient with a high hypertension under Ozurdex. So you inject Ozurdex, you have 35 millimeter. Do not use Iluvien in this patient. And so if you select the patients that will not have hypertension under Ozurdex, the risk to have hypertension under Iluvien is very, very low. This is the second key message.
Okay, maybe I'm not going to say yes with you about the last statement, because sometimes we are having a high blood pressure with Ozurdex, but we can manage and treat this patient. They are responding to the treatment and they are very nice. When we give Iluvien, because the dose is very less and it is not high, the pressure is not increasing. I have a patient like this. So it is not a rule, I think. This is my opinion. If
Okay.
Dr. Ahmed Salam, he's a vitreoretinal also with us, he can join us about and give his opinion about this one.
Well, thank you so much, Dr. Amri, and thank you so much, Professor Lauren. This is a beautiful presentation.
Thank you.
I think it's a very nice, very well-balanced presentation, and that's what I see. I share the opinion about the importance of retrospective studies. But I think when you come to like safety, I think you need to consider also what you get from randomized studies, because I think the reason why surgery rate was higher in the FAME study was that they were looked after more closely. And I think in real life, we don't do visual fields that they would do in randomized studies. You also there are lots of implications that you may need to defer surgery and wait a bit more. So I think I would consider both, but I totally agree with you. Real world studies gives very important information, especially for patients, for example, second eye or certain levels of vision that are not included in other studies. As for Ozurdex Iluvien, I agree with Professor Lauren. If pressure goes high with Ozurdex, usually it goes high with Iluvien, and we see this in diabetic and in uveitic patients. I think it doesn't mean that you do not treat them. I think you need to treat them, but just be wary, follow these patients, follow the pressure, and also warn them about that they may need a filtering surgery. And for you in diabetics, there are other treatment, but uveitic, sometimes really there are not lots of treatment options, and we still use steroids even in hypertensive steroid responders.
Thank you, Dr. Ahmed. There is only 1 minute. We will finish about about Dr. Laurent presentation about the treatment of the patient. I mean, second after, I mean, you give Iluvien, then to give Ozurdex or to give any other treatments, after which time you have to give. And this one question. The other question, you know, usually when we are delaying the patient for giving the Ozurdex or giving Iluvien, so we are making there is a more chance of ischemic changes. There is a lot of delay. So the response, it will be very less. But if we treat this patient by Iluvien as early as possible, I think the result, it can be more. Your comment, Dr. Laurent, and then Dr. Ahmed, very short, please.
I agree with your two comments, Dr. Ahmed.
Yes, sir. Yes, no, and I agree as well, Dr. Lamri. I think delaying these patients really affects the vision. And I think one important point is a good measure of the quality of treatment and the quality of the service is to look at absolute vision rather than lines of gain. Because if you treat patients early, they will have good vision. They will not increase so many lines, but their absolute vision is much better. And that's, at the end of the day, that's what's important for patients. So I think, yes, the message is clear. Treat patients early. Don't be sad because they did not gain many lines, but look at absolute vision.
The question also, Ahmed, maybe you missed, or Dr. Laurent, about when we can give the, I mean, for how long we can, you can say it in the other way, for how long we can wait for Iluvien to see the result before we think to give top up of these patients.
I think the graph that Professor Lauren showed was so beautiful, really, what happens with fluocinolone in general. So I would really consider that.
Yes, I think it's a good question. The efficacy, the mean of the efficacy with Iluvien is between 6 to 8 months. So you have to wait 6 to 8 months. But sometimes in 1 or 2 months, you already have the efficacy. And sometimes you have to wait 9 to 12 months to obtain the efficacy. So I do not consider to re-inject a second Iluvien before 1 year. And in most cases, I re-inject between second and third year. And I do not hesitate to inject one or a second Ozurdex during the first year of treatment to wait for obtaining the Iluvien efficacy.
Thank you very much, Dr. Lawrence, and thanks, Dr. Ahmed. We can have now Dr. Ahmed Salam, veterinary retinal surgeon, our friend, and we have seen him many times. So this place, I am a guest for him today, not.
Yes. Well, thank you so much. It's always lovely, and I've enjoyed Professor Lauren's presentation. Let me share my screen. I'll move away from science to something a little bit funny, and I hope it would be useful. I thought with the New Year spirit. So I call this funny implants. And I know I used to live in England, and Nancy would know that. Funny means in England 2 things, haha and peculiar. And I think these implants here are both haha and peculiar. So can you see my screen?
Yes.
Okay. All right. Yes, so Ahmed, let's go ahead, please. Yeah.
Yeah, implants like Iluvien and Ozurdex, and implant like Iluvien and Ozurdex and Reticert are very nice implants. But when you use them in context of other surgery, particularly vitreoretinal surgery, they could behave in a very funny way. So just before, for anterior segment colleagues, if you're going to do cataract and Ozurdex, and I do a lot of that with diabetics and more with uveitis, then the best way to do the Ozurdex or the Iluvin implant is when the viscoelastic is still inside the eye. And then you do it, and then after that, wash the viscoelastic. The eye is firm, and this is a very good time to do the implant. Then here you would remove the malusion ring and then wash the viscoelastic. But do it with the eye firm, much easier. Then, okay, well, let's see when we combined Ozurdex with vitreoretinal surgery, what happens. And I like doing this, particularly in uveitic patients. We published on this, and I think it's very useful, really, to decrease the inflammation that happens, especially in uveitic patients. It's also a good way of treating pre-existing diabetic macular edema for convenience, or in very long delamination surgery where you want to decrease the risk of edema afterwards, particularly if there was peeling and a lot of laser. We use Ozurdex as well. Or Iluvin. Let me show you what happens with Iluvin in two cases here. This is Iluvin here. So let's see what happens. So here, end of the surgery, I'm giving Iluvin. This patient actually had Ozurdex, and this was a very difficult case that we needed, as Professor Loren was saying, long-term control. She was diabetic with macular edema, and at the same time, she had panuveitis related to scleroderma. So really, she had Ozurdex before cataracts, before vitrectomy surgery. I've managed to preserve it and not remove it during vitrectomy surgery for vitreous hemorrhage. And now I thought, okay, let's put Iluvin for long-term control. So I think noble thought. And that's the Iluvin here. And then see what happens here. Right, so it shot out of the eye. So these implants can be very funny. It's very slender, very small. So just be wary that even they can shoot up to 20 through a 25 port. They wouldn't shoot through a 27 port. So then we put it back in the eye. Okay, I'll show you a next case. This is a patient with hypotony, again with uveitis. And what happened with this patient is she had Iluvin before the surgery to try to treat her uveitis and also raise her eye pressure. Then we gave up really on the hypotony. The hypotony was very bad, and we decided to put silicone oil inside the eye. It's actually not a very good treatment for uveitis, for hypotony, because it does not, it corrects it like temporary, but then does not correct it. But anyway, that's what we did here. And look what happens on this Iluvin present in the eye. So we were indenting the eye at the end, making sure no tear. So what happened really, it went inside the infusion cannula. And then it shot back inside the eye. So it's very, very slender, very small. So just be wary of all these things if you are like me and like to put implants during vitreoretinal surgery, and then it will shoot inside the eye. So I think this is something, if a patient has Iluvin already, and I don't know if Professor Loren came across these patients had Iluvin already, and then you're doing a vitrectomy, just be wary of all these things. They can all happen. Okay, what about Ozurdex? So we talked about Iluvin. What about Ozurdex? So here you go. So this is how we put Ozurdex. We just take the trocar out and just put the Ozurdex at the end of the surgery. And we measured really the, and one of the problems, it shoots like a bullet. So really just be wary, don't shoot it to the temporal macula. There are some reports where it hit the macula and some reports where it caused bleeding. So we try to shoot it away from the macula. There's another neat way of shooting it is you shoot it in the trocar. It doesn't work very well with 25 gauge because it breaks and it may shoot out, but it works so well with 23 gauge. So you see 25, it may work, may not. Or it may break outside like what happened here. But 23 gauge, it works very well. You can shoot it through the trocar if you want. And then let me show you something else as well that can happen with these implants. So then you stuff it in with the light pipe. So if you want to do this, if you want to put Ozurdex with vitrectomy, do this before you, after you do the fluid air exchange. So don't put the Ozurdex, then do the fluid air exchange, because what happens, the air buoyancy pushes the Ozurdex implants toward the retina, and you can have really toxic effect on the retina, like the way if the Ozurdex or Iluvien moves to the front of the eye and cause toxicity to the cornea. And that's what happened in this case. So it was shot inside the eye, in the eye saline field, and then air fluid exchange. And that's not the best way to do it. So always shoot it in the air-filled eye and not before. And you'll see here what happens in this patient after you do the fluid air exchange. So don't. That actually this patient had on autofluorescence a mark of toxicity, which you'll see here, and like a dent. So it's more like a test reaction. So the message is really, and you can see here, the RPE changes from the mark. So the message is put it in air-filled eye. Let's, lastly on Ozurdex, I'll just show you an adventure. Many times when I try to preserve the Ozurdex during vitrectomy is very difficult, but in this case I was successful. This is a uveitic patient who developed rhegmatogenous retinal detachment. And you can see the Ozurdex attaches to the vitreous somewhere there. With the vitrectomy, it falls down. So I was here trying to just preserve it, which was successful so far. All right, so now it fell back. So in this patient, just for people interested in vitreoretinal surgery, I could not really find the real break. That was a laser break, and I could not find the causative break. You know, it's in this area. So one of the ways to do it is to do a drainage retinotomy and laser dry to dry, and that's what I did with this patient and gas, and she did so well. Okay, well, last, Reticert. Reticert is really a very effective treatment. If you imagine Reticert is 0.6 milligram. The Iluvien is about 0.2 milligrams. So actually it's like 3 Iluviens. And that's why it's much more effective in uveitis. So we do 1 a month or so for very bad uveitic patients. And we sometimes combine it with vitrectomy. And it's a very good implant. The main problem that happens with Reticert is this. I'll show you now. This is the main problem and the fear always, is that as you're holding it to get it inside the eye, it flies out. And the reason is it's a $20,000 implant. But luckily, the company gives you 2 implants. And then if you lose one, that's fine. They don't charge you for this. But the message really is don't lose a Reticert implant because it's so expensive. And that was what's said in the operating room when we lost it. All right, well, thank you so much.
Thank you very much, Ahmad. As usual, very interesting cases.
Thank you.
Just one question, Ahmad. If someone have, a vitrectomy and he have for diabetic retinopathy, and you have to do a silicone, then remove a silicone, then you find him an edema and you want to implant Ozurdex, because you want to give, especially if he is having. So you cannot give, anti-VEGF. It will be a very short acting. So you will give Ozurdex or Iluvien.
Yes.
How you think it will be? How it will?
There is one of the retrospective studies from England was looked at the behavior in vitrectomized eye, and the half-life really was not significantly shortened at all. That's from I think Dr. Merrilla's group from Portugal and another group from England, where they combined their cases. And for the Ozurdex, we know from the Chaplin study that the half-life is not affected. So I think, yes, it's a good treatment in vitrectomized eye, really.
How about the effect and side effect of that? To hit
side effects
and hit retina and to have toxicity.
Yeah, I would. The only thing I would say, 2 things really, is aim so that it goes nasally. And even if it hits the retina, I don't think any problem happens. We saw hemorrhage before. We did not see anything more than this. but it shoots like a bullet. But shoot it temporal so it goes nasally. That's what I do. The other thing, if you're gonna fill the eye with air, then fill the eye with air first, then put the implant. These are the two things I would say.
No, I mean, if you do it after, not during the surgery, Ahmed. I'm thinking about patient already have a surgery and everything was good. Then you remove silicone and there is nothing. Then you find him an edema after a while.
So you do it in the clinic and it's a vitrectomized eye?
Yeah.
I think nothing would happen really. You may want to try to press it slowly, gradually, as Ozurdex would suggest, but we've never seen any problem in this context. Okay. I would just not shoot it. I would shoot it like to go nasal. So shoot it from temporal, anywhere temporal, so that it goes nasal. That's what I would suggest.
Lower nasal, right? Better.
I think any nasal. I would just keep away from the macula, and that's just my thinking, really. Okay. And also be wary with something in vitrectomized eye. The eye can collapse in the clinic. So just be wary to press and wait. If it collapses, I don't think it's a big deal. We had that with few vitrectomized patients. It will form in half an hour or so.
That's good. Great, Ahmed. Thanks a lot.
Appreciate Thank you so much. Thank
you sharing with us your experience. Dr. Lawrence, thank you. It was a great sessions about the anterior posterior segment. Now we will move to the
real segment.
Yes, congratulations, Ahmed. Very nice.
Thank you so much.
Congratulations.
Thank you.
Okay. We'll have the first presentation. It will be by Dr. Nancy. Dr. Nancy is a cataract, refractive, and cornea surgeon in, I think, in Jordan,
Medical Services.
Yeah, military medical services. Yeah. Okay, Dr. Nancy, please.
Thank you very much. So it feels creepy to speak after the VR people. So thank you for the invitation, Dr. Mohammed. And so I'll share my screen. And I'll be talking about unlocking a corneal dilemma. And before I start, a dilemma is a situation in which, hold on, I just need to do something. Let's remove this. So a dilemma is a situation in which a difficult choice has to be made between two or more alternatives, and especially ones that are equally undesirable. And why did I choose this case? I chose it because of its complexity, because it will teach us how to manage infective keratitis, because I learned when to surgically intervene, about the timing and the planning, and how to come with the best measures, and also how to prepare yourself preoperatively and postoperatively with appropriate workup. So my case is a 41 years old male patient who's known to have keratoconus. And I know that the photo seems terrifying. He was referred to my clinic with a bad left eye keratitis that was not resolving on antimicrobial treatment for 3 months duration. And his initial culture showed no growth. One of the things that I've learned through my experience in dealing with infective keratitis, that it's better you go after your sense of what's going on rather than rely on what the lab could tell you. So I did not stop there, and I took a 3 millimeter corneal biopsy, was taken from the edge of the infiltrate, and it came back with full of cysts of acanthamoeba. So the next stage, I started treatment, and the protocol was started at that time. When he presented, we didn't have proper anti-acanthamoeba treatment in Jordan. We were limited in resources, but we could, I could write up to more fields at that time and get, with the help of some friends, some proper anti-acanthamoeba treatment. So we got the PHMB, which is polyhexamethylene biguanide, and proline, and I started a protocol that I've learned from John Dart, who wrote an article that I consider is the Bible of acanthamoeba treatment. So we bombarded him with PHMB and Proline for the first 48 hours, every hour, day and night, and then I started tapering it after a few weeks. On the third week, I was brave to kick in some mild topical steroid, which is fluoromethalone, in order to curb the inflammation. Now, the process of controlling his infection took around 9 months. We had good days and bad days. We had to go back to, like, we go down to 3-4 times of drops for a week, and then the eye flares up, and then we increase the dose again, and it was like that, like a seesaw of or a roller coaster of good and bad days, until we could control everything. And now, his best corrected visual acuity at that time was hand motion, and when I could bravely lift all anti-acanthamoeba treatment and keep the patient on steroids and lubricants, it took me around 12 months. And when I started seeing scarring, that was a relief. And of course, for any infective keratitis, corneal neovascularization is a very good sign, because then you know that it's starting to settling. And I focused on managing that vascularization with anti-VEGF treatment. I used Avastin, and I used 3 injections that were 1 month apart. And at that stage, I could curb the inflammation, the infection, and the vascularization. And after that, it was time for my visual rehabilitation. Now, every time I talk about this patient, I remember a phrase by Shakespeare that he says, "When sorrows come, they come not single spies, but in battalions." And in Arabic, we say, "Al-masa'ib la ta'ti furada." And this is this patient. So he has a scarred cornea on the left, a barely settled infective keratitis, an eye that is keratoconus, a cataract that is behind, a verge of glaucoma because it is associated with acanthamoeba keratitis in a high percentage of patients. On the other side, his right eye has keratoconus that was grafted a few years ago, and he has a high myopic astigmatism. So which eye first, which problem first, which way to choose? And I always say, when I am in a complex situation, that I divide my problems and put them in front of my eyes. So the right eye had a best corrected visual acuity of 0.6, it's keratoconic and grafted, and there was and cataract surgery was done, and refractive surprise resulted with a myopia of -4, -13.5 astigmatism. Now, the left eye, on the other hand, had a best corrected visual acuity of hand motion, recently recovered bud infection, vascularized, white cataract, and also keratoconus. So I put my concerns in front of myself in order to pick which one I would deal with. So I treated the acanthamoeba, and I want to do visual rehab. And my plan was to do a visual penetrating keratoplasty, luckily, because we all know that therapeutic PK would have a very poor prognosis in these patients, and a visual PK carries a very good result. And putting in mind that when I do his PK, I need to use a very high dose of steroids at the beginning. So I'm putting the risk of flaring up of his condition. So I have to balance his medication. This was one of my concerns, that the cysts might not be killed yet, and it would be hidden in the angle. And when I give him this high dose of steroids at the beginning, then it will help exocyst the cyst into trophozoite, and then the cycle will repeat itself again. And actually, when you see a patient who has acanthamoeba with the traumatic experience of the pain, the insomnia, the nights that they can't sleep, you cannot just tell him that my surgery might flare up your condition, and you would go back again to square number one. So this is one of the things that was in mind. The second thing, what about the white cataract behind? Would I remove the cataract at that time of PK? And if I would I risk repeating the refractive surprise in his right eye and deal with it later? And if not, which formula to use, which IOL to choose, or which lens type to implant? And the other question would be, would you keep the lens and phacoulator? But if you do that, you did not visually rehabilitate it, because the vision would still be the same with a white cataract, and also you would endanger his new graft with a possibly difficult phacoulator on. So while all these questions were brewing in my mind, I did some workup for the sake of just checking what might go on. And we all know that IOL power calculation in keratoconus patients is complex and unpredictable, and the most challenging part of the preoperative consideration, especially in moderate and severe cases. Now, our eye is not moderate or severe. It's a keratoconus, and it has a long axial length. So this is the pentacam of the eye. You see very irregular, very distorted. And actually, it was very mixing to look at the different IOL masters that came back. So the Holiday, the third generation IOL master formulas, they gave us conflicting powers. The Holiday gave me a minus 0.5. The manual biometry gave me a plano, and I used the Holiday report, the EKR 65, in order I used the K readings from that. And the SRK2 gave me a plus 0.5. The Hay gaze gave me 1. The SRK2 gave me a 7. And at that time, there wasn't a ballot formula yet in that machine. But I did not worry much. My decision was to do a PKP, yes, and I wouldn't leave a white lens in place, so I did an open sky extracapsular cataract extraction. But and my question is to you: would you implant an IOL depending on inconsistent keratometry? And the inconsistency comes from the fact that the visual axis of this keratoconus eye might not pass through the steepest part of the cornea, and the radius of curvature is reduced, so the effect of the keratometric error is increased, and the irregularity of the tear film reflex make it difficult to identify. So it would give me non-reliable, non-repeatable K values. And not to say that there will be a change in the axial length when you do a graft, and the effective lens position, of course, will change. So the geometrical structure of the whole anterior segment will change. Why should I have to deal or worry with an eye that will change its face? So what did I do? I grafted the patient, and this is how it looked like the first week post-operatively. And I've done my extracapsular cataract extraction, but I left the patient aphakic. I left a viscoelastic inside the edges of the capsule all around the equator, and I know that was a desperate measure to keep it open, and sooner or later it might close. And I made sure my sutures are as regular as possible to make sure that not to interfere with any refractive error apart from the astigmatism that might result. And I kept a close eye on maintaining regular remodeling of his graft by avoiding any suture manipulation and early intervention if I saw any sign of change on his post-operative topography, which means any loose stitch in the first period would be replaced. Any tight stitch will be loosened to keep as regular as possible. And you can see that the lower pentacam shows his eye before grafting, and the higher pentacam shows how regular his cornea is 3 months after surgery. And his refraction was plus 12.5 with minimal astigmatism of 1.5. And this is exactly what I aim to do. And I was brave to do his IOL master after a few months in order to see where did I take him. And it is a beautiful thing to see for a surgeon, a cornea or cataract surgeon, to see that all the formula agree on the same number. So you don't have to pick between people or formulas. So the SRKT and the Holiday one and the Barrett Universal all agreed that his biometry is the same and falls within the 19.5 or 20 diopter. So I went in and I inserted the lens. The capsule was very easy to open with no fibrosis. I'm not sure if this is luck or the Helan that I've left there did anything. I inserted it in the bag so smoothly. And 8 months down the line, his refraction is almost plano with a bit of astigmatism of minus 4.75 that corrects to 0.7. And to my pleasure, the management of the suture-related astigmatism later is as any usual or a course of penetrating keratoplasty. So I gave him time to settle, and I think we're scheduling him next week to do something for his around 5 degrees of astigmatism. And what I like to do is to do a selective suture removal, and I might offer him some surface ablation later on, or do some arcuate keratectomy. Now, the way I treat young individuals with penetrating keratoplasty is that I never remove the sutures all together. And I teach this to my fellows and residents, that especially in young individuals, the cornea is a very forgiving, but at the same time, it is a very repelling tissue. So it remodels itself so quickly. And if you remove the stitches early in a young patient, you will get remodeling that's so fast that even the interface will change its face completely. Don't rely on seeing a scar in the interface, and make sure that you keep at least 4 stitches in the eye to hold it in place. This does not apply on old corneas or old people, because the remodeling process is very slow and it wouldn't affect the outcome. And any astigmatism that is above 4.5 diopters, I do remove the stitches. Otherwise, I never, and keep them for a lifetime. What is the take-home message or lessons to learn? Keratoconus is very common in our part of the world. So learning how to deal with ocular comorbidity is a necessity. You don't have to be a cornea surgeon, because sometimes you have to make decisions in these patients, and cataract and IOL calculation is very associated with keratoconus. And these patients depend, a lot of patients depend on contact lens wear, so corneal problems accompanying them is a topic that a lot of ophthalmologists should be able to cover comprehensively. There's also no universal consensus on treatment strategies in the presence of multiple ocular comorbidities. So the way I dealt with this patient is not the way anybody else would have done it, but it's important to prioritize your treatment plan and address the key problem and work around it to come out with best outcome measures. And before I say thank you to you, I'm really interested to know my colleagues, anterior and posterior segment, what would they've done if they were in my place. So thank you very much.
Thank you very much, Dr. Nancy, for this excellent presentation and very nice management. Actually, I will introduce now my dear friend, Dr. Osama Jledi. He's a consultant cataract and refractive surgeon in Warfield Hospital, and he will discuss the case and do the moderating for this part of the session. Dr. Osama, mic with you, please.
Good evening, everyone. Thank you, Dr. Mohammed, and thank you, Nancy, for this interesting case.
You're welcome.
I think it's always challenged these things, and everyone had different, and the patient, what you need to involve the patient decision making, for example, to put the implant or not. For me, I think I will put the implant and do the like 43.5 or 44K reading. And also you can check the other eye, because you have the cornea graft and axial lens, so you can use the other eye to help you to get between the numbers. So you can figure out a little bit more from other eye also.
Yeah, that's correct. Now, one of the things is that the other eye has a best corrected visual acuity of 0.6, and he has a very high astigmatism of almost 13.5. And I remember that I saw him today. He has a astigmatism of -18, actually. I didn't have time to just rectify my lecture. So a -18 astigmatism is kind of a very high refractive error to deal with. And I didn't want to put him through this. He had problem with contact lenses wear, so I wanted to do as much as possible, as optimum as possible treatment for his case. Now, one of the recommendation that I would do, if you wanted to implant a lens at the time of surgery, I would go for, I would use the Barrett's universal formula, 2 universal formula first, and I would go with undercorrecting it with, go myopic with 3 diopters, because usually the IOL calculation underestimates the size of the IOL power in patients with keratoconus.
Dr. Safan, what do you think? If you wear hair, what you do? The mic, Safan.
You are mute, Dr. Safan, please.
Sorry,
Okay.
I'm very sorry. I'm very sorry. I'm very sorry, please, Dr. Mohammed. I'm very sorry for that. The issues is that I do agree for certain cases, like the case that Dr. Nancy presented, is a corneal scar and previous keratoconus. That's why this challenge pushed her to make the patient aphakic. But in case that we need to go through and to do an implantation simultaneously, as you said, that I will target 43 or 44, and the aiming sphere, it will be -3 or -4. Now, in a usual keratoconus with K reading beyond 50, 55, I'm doing that. I'm targeting 43, 44, and -3 at least. Then I'm getting a better result than over hyperopic shift and overcorrection. But if we have a chance like what she had and keep the patient aphakic, I think that she will have a better result than that what she had. That if she had the chance, she's the surgeon. She's the surgeon that she will do that. She did the PKP, and she's the surgeon that she dealt with an infection. But if we are dealing with the surgeon that is dealing with infection, and then the other surgeon dealing with the PKP, the story will be different because there will be a two opinion. So she did a strategy that was unique, and I think that I need to congratulate her. That was a good option.
Thank you very much, Dr. Safwan. And yes, it's a very excellent point that you've highlighted, that it's very important to work around the strategy. So you said a very valid point. If you're the surgeon who's going to take the patient through the whole journey, then it's up to you. But in many cases, you know, we work like referral centers, and you might treat the infection and the patient then disappears, and you have to deal with the refractive outcome. And sometimes in certain situations, it's not we are blessed that we can do all the anterior segment work, but sometimes it does not work that way. So yes, thank you very much for highlighting this. So I would go with your point of making it myopic 3 or 4 diopters, because then you would make the surprise more controllable after surgery.
Exactly. The surprise from the sphere and cylinder. Now, because we post PKP, we have two things: the sphere and cylinder, how to deal with it. So as much as we will be able to deal with it in multiple issues, whether the ICL or the topical laser.
Dr. Ashraf, any comment? And Mike also. Yeah.
Dr. Ashraf.
Thank you. Congratulations. This is a very nice case, definitely. This makes the. Do you hear me? Yeah.
Yeah.
We are having interrupted, Dr. Ashraf.
Yes. So the sutures, the best, you take the suture in a very elegant way. So this makes the post-operative results great. But I'm asking, you did an extra capsular cataract extraction open sky. It was the Rexus, and if it was a can opener, do you put the methyl in the bag, and then you open it after 4 months from the can opener, or it was a capsular access?
Okay, because there was a little bit of a disconnection, let me just rephrase the question and correct me if I'm wrong. You're asking if the open sky ECCE was through a continuous Rexus or a can opener?
Yes, this is the question, please.
No, it was a continuous Rexus, of course, because I was planning to keep him aphakic and then come back with an IOL. So it was a CCC, and I've left a tucked-in viscoat, which is a heavy helon or heavy viscoelastic, I tucked it in the inside the capsule.
In the bag.
The bag, yes.
Yeah, this is what I am highlighting. Why? Because if you can opener, you're not going to have a chance to open the bag again.
Yes, I think so. That's why I found it so easy when I came back with a mushroom-shaped forceps. It just opened so easily. Yeah.
Dr. Osama, one point that Dr. Nancy, she highlighted that we are not removing the suture in one session. I just need to add for her talk, we are removing the suture in a topographic guided way.
Definitely.
That topographic guided way, it might take around nine months to finalize the issues, but it gives a very very excellent results, especially in the young patients. Yes, Dr. Osama.
Yeah, thank you very much.
Sama, we have two questions if you want to look, or you want me to read these two
Read them
questions.
if you can.
Okay, when you put IOL after BKB, do you give oral steroid before that?
I have a problem with oral steroids in penetrating keratoplasty patients. I don't know why. I think they have no role, and I will be brave enough to broadcast this. I wouldn't give oral steroids because systemic steroids is used in penetrating keratoplasty only in the context of rejection. And in order to avoid this or to treat this, I give systemic steroids. So to me, whether I'm fearing rejection or treating rejection, I wouldn't go for oral, and I'd go for only IV methylprednisolone. So no, I wouldn't. The second thing is that this is a recovered acanthamoeba keratitis patient, and I wouldn't give a high dose of steroids before putting an IOL.
Is there any other comment from other colleagues about this one? If you are in the place of Dr. Nancy, would you give steroid or not? Or you will be also cautious not to give? Dr. Ashraf, Dr.
No,
yes or no?
No steroid.
No steroid. Safwan?
No
Steroid. I'm dealing now with a patient, complicated acanthamoeba, and I crossed the 3 months. Now she's healing. I think that Osama, he know her. Now she's in her way for healing and the epithelialization, but till now I didn't give the steroid. Nancy, maybe she's more brave than us that she start a steroid after 3 months. No, for me, no, I will not.
Okay. How was? I'm sorry. How was the IOP post PKB, Dr. Nancy?
Now, it's a scarred cornea. If you want to see, we go back. So I wouldn't rely a lot on the tonometry. It's in the high teens, 17, 18. And I do give all my patients of penetrating keratoplasty, especially infection, a dose of anti-glaucoma until I make sure that everything is fine. So I did expect glaucoma to happen.
Thank you very much, Dr. Nancy. Okay, Dr. Osama.
I didn't see Mazen there. So
no, Dr. Mazen, I want to apologize on behalf of Dr. Mazen. He has some situations that he cannot make it and he cannot attend. So we can go directly to Dr. Ashraf. Okay, Dr. Osama.
Dr. Ashraf, it's really a pleasure to have you with us. I think you don't need to introduce it. Everyone knows you by now. You're almost active every week, I think. We see you, and it's a really pleasure to have you with us. And I think you're going to present it when there's a congenital lens problem situation, how to deal with that.
Thank you, Dr. Osama, and thanks, Dr. Ahmed and Dr. Safwan for the kind invitation. It's a pleasure to be among, and for sure, Nancy also. I'm going to talk about congenital lens anomaly, and I'm going to highlight only on 2 of them. I feel they are rare to find and they need a better management. So I'm going to share my screen now.
Be careful, Muhammad. He's waiting for any mistake.
Yes.
No worries. I will wait only for you, Dr. Safwan. For Dr. Ashraf, no.
That's why you kept me for the last one. That's why you kept me for the last. I'm waiting for that.
No, because the last I know is the one. It will be very strong.
Yeah, I know.
Okay, I have no financial disclosure about my presentation regarding any of the brands I'm going to talk about. So congenital anomaly, when we face a congenital anomaly of the lens, we have to be careful examination of the infant. Soon after birth may reveal congenital anomalies, opacities in the transparent structure, a lack of parallelism and albinism, and or uncorrected high refractive error in one eye that may interfere with the normal development of the binocular vision, which may continue until the age of 10, depending on the simultaneous and nearly identical bifoveal image formation in both eyes. So the first thing I'm going to talk about is a spherophakia isolated and not the spherophakia in general. So it has an ocular features like small spherical lenses, has a lenticular myopia, but does not have an increase in the axial length. Glaucoma has been reported, and there is no ophthalmos, and the lens may subluxate in the vitreous cavity. It has some no skeletal or cardiovascular metabolic diseases. There is no systemic features. This is the spherophakia isolated. In the genetic view, it's an isolated spherophakia. It's an autosomal recessive disorder resulting in homogeneous mutation, and it has a parental consanguinity was present in the reported families. The pedigree is autosomal recessive, and the treatment should require extraction of the for the secondary glaucoma that may happen, and also for visual rehabilitation. But we have a spherophakia that may contain systemic disorders. This is a genetically heterogeneous disorder and usually found in association with another systemic finding, like the Wilmer-Schizani syndrome or the Wilmer-Schizani-Light syndrome. It's called, the condition contains megalocornea, ectopia, lens, and the spherophakia. There is another form called the spherophakia with the hernia, sulfatile oxidase deficiency, primary congenital glaucoma, and this syndrome is called as spherophakia and metaphyseal dysplasia. So this is the spherophakia in general. It is not the spherophakia only. So this is a narrated video. I'm going to present it now about a case of spherophakia. I'm going to stop. The video is already narrated.
Dr. Ashraf, is it with the voice or without?
Sorry?
We are
Cannot
not
hear the
here.
voice.
We cannot hear the voice. We are only seeing. Is that how it will work, or?
No, it's a narrated video.
We are seeing only a written things, but without any sound, any.
Without any sound.
Okay, I can narrate the video. Okay. So this was my plan to use the flax in this case to get the perfect size of the capsular rhexis, and I used the CTR to stretch the bag against the elastic zonules, helping me to succeed to implant single-piece hydrophobic IOL inside the bag. So when I did the slit lamp, it was very clear it's a spherophakia, and the other surgeon for the other eye did the eye. He didn't take all the precautions, and I did the UPM to make sure that the eye is a spherophakia, and it showed me very well that the eye is a spherophakia case. So in these cases, you should plan before you go to the eye. Before you touch, you have a good plan for these cases. The most important to do a good size rhexis, and this is not easy to do it manually. So I choose the flex to do it. I tried to do also the nuclear fragmentation, but the machine didn't detect the posterior capsule. So I stopped and only did the anterior rhexis. See, even after I did the capsule rhexis, it not to remove this capsule rhexis done by the laser. It was very difficult because see, there is a severely laxated lens, and the zonules was very elastic. So after some time, I succeeded to remove the anterior capsule, and I wanted to be sure that it is continuous. In these cases, I usually deliver the lens outside this subluxated or laxity bag. I use a double coat viscoelastic, and I did the takeoff from inside the nucleus, and I left the core of the core, which is not so hard. Now I finished the case. but don't go out. Inject. Viscodispersive is very important because you are going to see now how the bags are so lax. Even when you take the cortex, you can bring the bag with you.
Ashraf, the movies is not moving in well, and we are not hearing you.
I think Dr. Ashraf is having a problem in
And
connection.
I leave many times because I stay the anterior tool in the back. You cannot hear me, Dr.
No.
Yeah, we can hear, but it is interrupted, Dr. Ashraf. No problem. You can continue, please.
Do you hear me?
Yes, yes, go ahead. Can you continue, Dr. Ashraf? You are with us? You can hear me? I think there is some. Okay.
Okay.
But still interrupted. Dr. Ashraf? I think Osama, we lost Dr. Ashraf. So
I think he will reconnect up. 1 second.
Let us. Yeah, Dr. Ashraf, I think you have some problem with connection. Yeah, we cannot. Okay, if you want to continue.
Yeah, I have some internet problems. Yes. Yeah. So, do you hear me now well? Yeah.
Yes. Yes. Go ahead. Yes.
Okay. So it was difficult
fine, yeah.
to see how the bag is lax, and I couldn't remove easily the cortex, but I was helped by the irrigation behind the pieces. See, you are stretching all the bag, but I succeeded at the end. But every time, don't lose the anterior chamber depths, because if you lose it, you are going to lose this weak zonules. See how the bag is lax. I can see all the zonules, but I succeeded to put a CTR, but it was not an easy. Also, I had a problem in the CTR during implantation, but I succeeded to put it inside the bag. And I succeeded to put a single piece IOL inside the bag. Very important to see. If you find that your rexus is still central, this means that the eye is still, the zonules are okay. And this is how it looks post-operative. This is the left eye when we use the manual extra capsule, manual rexus, and he didn't do it, and displaced IOL with high astigmatism. And this is our case, and we left this eye with a 0.25 sphere and minus 0.75 astigmatism with a 20/20 vision. So this is what my home take message in these cases, that well preparing yourself before you are taking your case can give you the proper post-operative. The proper diagnosis of the cataract spherophakia using the flex can rescue the tools in these eyes. The other type of congenital anomaly is the posterior lenticonus, and they tend to be unilateral. There is no evidence that there is a familiar condition. It is suggested that the bilateral posterior lenticonus may be inherited in an X-linked fashion, and it's sharply demarcated posteriorly. It's conical projection of the posterior capsule and the cortex of the lens, and it's uncommon, and it is usually unilateral in all my cases. Has a prevalence? Yes, posterior lenticonus is more common than anterior lenticonus, sporadic and inherited cases, particularly the X-lensed, and it's zomal dominant. The etiology has a lot of etiology, but most common with the Albert syndrome, with the microcornea and the anterior lentiplanus. And it has very important clinical features. It usually present at birth. Amblyopia is present. It's an isolated ocular finding. It is a slight female predominance. It's unilateral more than bilateral. It has a high degree of astigmatism. Retinoscopy shows the distortomyopic reflex, and the slit lamp is very clear with a cone shape, and the progression of the cone surrounding the lamellae may opacify. This is the gross histopathology, and the treatment of these cases usually remove it and put the IOL inside the bag. In how we're going to be in this video. So in posterior keratoconus, how you are going to do, you should have a good anterior rhexis, because if you fail to put the rhexis, the IOL inside the bag, you're going to have an optic capture of the anterior rhexis. So this is a child, 3 months, unilateral posterior lenticonus, and as normal in these cases, we open with the cystome first and controlling your anterior rhexis in these cases because it is a highly elastic. Usually, many catch of the anterior rhexis till you do it in a very nice circular way. Don't leave it to extend. Always bring it to the center slowly, and many catches many times close to the area you are going to leave make you have a good size anterior rhexis on these cases. Then don't do hydrodissection at all. And when you remove your cortex, you just bring it to the center. Don't go for removal of the cortex. You just bring it to the center to leave, which is the already opened posterior capsule till the end. After you finish this half of the lens, just bringing all the cortex to the center. Don't go for all removal. This is very important. Change your hand, but don't leave the anterior chamber to loose. You should inject viscodispersive. Then change your hand. Again, do the same. Bring all the cortex to the center. Don't remove it now. Don't remove the last piece. Leave part attached to the area already opened. As you do this, you are going to remove it as one block with no disturbance of the vitreous. Now we are going to deal with the posterior lenticonus. So you make a small snip at the edge of the cone, then injecting viscodispersive under the posterior capsule in the Burgers area to separate the anterior vitreous from the posterior capsule. And in these lovely cases, you are going to do a posterior rhexis in a very neat way because you have already separated a part in a circular manner. You are going to see it now. It's not difficult. You are going to remove it in a highly neat circular way with no tags at all, in a very neat posterior capsule. Anterior vitrectomy is done. And after this, very important to open the 2 leaflets of the anterior and posterior to make a space to put your single piece hydrophobic inside the bag. Don't go for the IOL directly inside the bag. Put it above the anterior capsule or above the iris. Leave the IOL to open freely. Then make your haptic slowly under the anterior capsule. And as you are sure, then rotate it in a horizontal manner to make the other haptic inside the bag. And now you are inside the bag and everything, and you take sutures of everything, and don't forget to inject subtenon steroids. And then I remove the suture after 3 months and usually record the cases. See how it's like after 3 months? Very neat anterior capsule, and the posterior capsule is very neat, and the visual acuity, the visual axis is clear. So my take-home message in these congenital cases, because these conditions need time, need proper management by the ophthalmologist. It's not a day, it's not an operation, it's lifelong with the patient. you should tell her parents this. Early detection is mandatory, so the eyes do not suffer from vision deprivation leading to amblyopia and poor vision. Thank you so much.
Thank you very much, Dr. Ashraf. That's very great. One question, Dr. Ashraf, for the microspherophakia. Why didn't do the tension ring at early stage a bit?
Yes, I didn't do in early stage because if I put the capsular tension ring in these cases, it will be difficult to remove these cortex in this very weak zonules, because I don't have the chance to do a counteraction. So the best way, if I do it again, I may put capsular hooks during my irrigation aspiration or during my removal of the cortex. May help me sometime because I'm going to have the counter pressure by the capsular hooks. It may make the operation more easy if I did it again.
Thank you.
Yeah. The same. I prefer to put the tension ring after the removal of the lens, because as Dr. Ashraf said, that the removal of the lens matter after putting the, or when you are putting the tension ring before removal of the lens, it's very difficult, and it's carry a lot of complications, especially when you are we need to remove it from the periphery.
Yes.
Osama, is there one question and comment you want to?
You need to do anterior vitrectomy for the second case, I think, the doctor.
Yes.
Yes, I did anterior vitrectomy.
But do you need to do it?
Yes, I did anterior vitrectomy for the lenticone.
No, but do you need to do it?
Sorry?
Or you could go? Do you need to do it, or you may leave it without? If you had.
No, I usually do it. Because the anterior vitreous face is going to be a scaffold that the cells can go in front. But I only don't do it if I'm going to put a three-piece IOL inside the bag and then do a posterior capture in the posterior excess. I may not use it. But removing also of the anterior vitreous decreases the incidence of post-operative glaucoma for these patients. So it's better to remove part of the anterior vitreous face.
Exactly.
Osama, there is one comment, I think. We have one comment, Dr. Osama, from Dr. Marwan Ghabra. I think he's a well-known figure also in refractive and cataract surgeon. He said, I put the IOL before posterior capsular excess. Can we have Dr. Marwan Ghabra weigh live if we can? Dr. Marwan, can you connect with us? Is there a raised hand, John? Okay, meanwhile.
He will put the lens before doing the posterior capsular excess.
Yes, posterior capsular excess.
I can comment. Yes, it's
okay.
You can do this, but you are going to have you should put a trocar to make it easily to be through the anterior vitrectomy.
Yes.
Sometimes you can put the IOL inside the bag and you make it to one side. Then you do your by oculotomy, you can do the posterior excess and anterior vitrectomy. But in my hand, I usually do it clearly before the IOL, then I put the IOL. But this is another technique. It's sometimes it can help.
Yeah. How old is Dr. Okay, Dr. Marwan Ghabra with us. Okay, Dr. Marwan.
Hello, everybody. Thank you very much for your effort and help and really very comprehensive lectures. What I'll do normally after I do the anterior capsular excess, I put half of the implant in the bag and the other half is open. I do the capsular excess underneath the IOL, and if needed, I do anterior vitrectomy. It'll be easier for the lens to slide in only with one haptic already in the bag. And I have a couple, series of videos about this technique, and it works very nicely.
Okay, is there any comment or question to Dr. Marwan from the panel?
Dr. Muhammad, the why we are putting, Dr. Marwan is mean that when we are doing the posterior capsular excess, implanting the lens into the bag, it carry a risk of rupturing the posterior capsule. So putting one haptics it makes the life easy. Well, I think that I saw Ashraf, he's putting it in the sulcus, and then he's taking one haptic by one haptic, and still in my hand, what I'm doing is that I'm keeping the viscoelastic, the cohesive, dispersive behind, covering the posterior capsule, and then implanting haptic by haptic to the bag. Because even if we are putting one haptic in the bag, it will interfere with our movement and injecting the dispersive material behind the capsule, which is the key factor in doing the posterior capsulorhexis in a right way. That's my opinion.
Dr. Marwan, if you have anything to add before we move to the next.
I mean, I fully understand your point, but I mean, it's a matter of how surgeon comfortable in doing it.
Yeah.
And
Right.
I think it is doable, and the more you do it, the more you feel comfortable in doing that. I found myself manipulating the intraocular lens after doing the posterior capsulorhexis could be dangerous. I'm not sure, this is my own opinion. By implanting one haptic, and then once you do the capsulorhexis, the posterior vitrectomy, then it's very easy to introduce the other haptic. I have one question to Dr. Ashraf. Have you tried use trifocal IOLs in pediatric cataracts?
Hi, Dr. Marwan. No, I didn't try to use the trifocal because, as you know for sure, Dr. Marwan, that the biometry may change, and we can have it correct, because this is a child 3 months old, so it's not an easy to put a trifocal in this case. But I use the trifocal when I do congenital cataract, maybe after 10 years. Sometimes I use trifocal, but if it is bilateral. If it's unilateral, I don't go for trifocal.
Oh, definitely not at age of 3 months, that's for sure. But yeah, from age of 8 and beyond, I have a bit of experience, not a huge experience, but I mean, it does work.
Okay, Dr. Osama.
The comment, please.
Yeah,
Dr.
please,
Nancy.
Hello, Dr. Marwan. It's nice to hear your voice again. So I just want to comment about the trifocal in children. I've used this a few times in children aged 8 and 9, because I think it's important to use trifocal sometimes, because even the near vision is important to avoid amblyopia. It's not only far vision, especially in the learning years. So I think this is something that we have to talk about more often, maybe. And it is an important topic. And thank you, Dr. Marwan, for bringing this up. It is something we have to consider, actually. And now we live in a kind of 2-3 meters of living world. So the distance is a little bit not as important as the near, with the learning and the accomplishment, especially for our upgrowing children. So I think this is something we have to consider. Thank you.
Thank you.
Thank you very much. I think we can go to the next speaker. I think
Sama, can we ask Dr. Ahmed, please? We can have Dr. Ahmed also opinion about the posterior segment.
Any one of the panelists you want an opinion, please let us know.
No, because I want to hear Dr. Ahmed actually.
Okay, fair enough.
Okay, Dr. Ahmed, please, because Dr. Ahmed.
Can you unmute, please?
Unmute, Dr. Ahmed.
I can comment about. I mean, actually, I have one comment.
Okay.
About the capsule tension ring implantation before the retractors. I had a very interesting case where I put the iris retractors, and the capsule retractors are hollow and they have a lumen. And then before putting the IOL, I put the capsule tension ring, and the capsule tension ring went inside the lumen of one of the retractors. I don't think this has been reported before, but for my frustration, I found that we did not record this case, but that was so interesting. I had to push it back. So I think the message maybe use an iris retractor, or just be wary of that complication. I thought it's just something interesting.
I can comment, Ahmed, on that.
Yeah.
You know that Chang last year changed the capsular hooks to closed because this problem.
Oh, because of the, sorry, here you go.
Yeah, the CTR, because it goes through the capsular hooks. And
yes,
he changed the design to closed loops not so prevent the CTR to go inside the capsule hook. This is
Yeah,
true.
I thought that was really very funny.
Yeah, it's a big problem.
And I just do the capsular X's as Ashraf, as you do it, the posterior capsular X. I shoot it directly in the bag. I think I find that shooting the lens directly in the bag is more controllable, but I think it's many ways to skin a posterior capsule or a lens.
You are a posterior segment, Ahmed. So if you
Good
lose the bag inside the IOL, you are going to bring it easily.
Okay, Sama, can we go to this?
Yeah, really it's a pleasure now to have our colleagues, my friend, dear friend, Dr. Safwan Bayati. He will present our case, but he didn't tell us what we're going to present. So we'll look what surprise he will bring to us.
Good evening, everybody. And I need to thank Dr. Muhammad and Dr. Osama for this invitation. And I think that I will share my presentation, and that's my presentation for a case that it's been discussed recently. And just 1 minute. And I tried to comment on it, but I couldn't because the meeting not allowing the comment. So such a case, whenever we need to have any comment on it, how we can treat a patient with RK having a problem with the vision. 47 years lady, she present with a very low vision. Unaided, it was, I think that I'm remembering that because I put all the nomogram and the parameter of the patients. She had 0.4 unaided by 0.3 or 0.4 for the other eye, and that reached 0.5 to 0.6 now, we will see. You can see that this are an RK, and whenever we are seeing this case, we are asking ourselves what we can do. The most controversy discussion will go through whether we will do LASIK by keratome or LASIK by femtosecond assisted or laser. And that's the controversy that it goes through. But we forget what we need to treat, a low order abrasion or high order abrasions. This patient suffering from what? From the RK, from the line that's there, or it will suffer from our treatment by doing LASIK, for example, for this patient to decide that we need to do a microkeratome, but we need to go deeper just to save these slices from getting triangles or a slice of a watermelon. Did ever any one of panel see LASIK done for such case, and then the cornea start to be a watermelon, triangles and open all? And that's what case that I saw. It's not in my hand. One of our colleague in Moorfield, he did it, Moorfield Hospital, England, and then he concentrate on how we treat the problem of this patient. It's not what's the way, because the way is the laser, in my opinion, to have a laser that can deal with this problems. And this problems, or the problem of this patient, is coming from the higher order patients. If we will go to the summary about what's pre-op and post-op for this lady, she has in the right eye 0.4 unaided and the left eye 0.3 unaided, reached to 0.6, 0.4 in the left. With a refraction, it seems to be reasonable for such an RK, plus 0.75 minus 0.75. That's in the right pre-op, and plus 1.25 minus 1.5 in the left. So it's not the problem of the low order abrasion for this kind of low vision distance and near. Her near, it's not better than N6 in both. So she was suffering a lot with +3. She was using +3 just to magnifying the image in a way that she can see or she can read. But if we will look at the high order abrasions, the high order abrasions in total for the right eye was 2.1, and for the left eye was 2.16, including 1.77 equivalent diopter of spherical abrasion and 1.8 equivalent diopter for the left. Comma was including 1.95 and for the right 1.98 for the left. Now, if we'll go to the corneal map, we can see this is the classical corneal map for RK, and we can see clearly on top tangential anterior top right how the central area is flat, showing by color code of blue, and the periphery is steep. That in the anterior and posterior elevation also shows the elevation of the periphery and the depression of the central area. Now, that's on the topography. The higher depressions for the right eye shows clearly that we had a high total amount of higher depressions with coma and spherical abrasion and trefoil. Sorry. The left eye shows the same, almost same picture and parameter for the right, with the higher depressions of total 2.6, as I said. Now, if we will go to how to treat those patients, the goal of the treatment of this patient is to treat the higher depressions. So it means that we are not asking for the visual outcome. I'm not talking about the visual outcome I'm not promising the patient for a visual outcome. Means that I'm not targeting when I'm treating those patients a zero. No, I'm trying to overcome the higher depressions, but not going through and having a hyperopic shift or under correction in a high value in a way that it will disturb the end result. So it's a challenge between treating the low order abrasions and treating the higher abrasions and end up with a good end result in a way that it will improve the quality and improve the acuity. So the target is to keep the consumption of tissue varies between the abrasion-free treatment profile and with abrasion. If we will go to abrasion-free as an example for the right eye, and we will see that we had 1.5 plus 1.5 minus 1. That was the refractive error of the patient when she presented. If we will go to see the consumptions of the tissue ablation down, we will see, I think that I will skip from here in a way that I can show the order. See, this is the consumption is around 56 microns. But if we will go to another slide, which will show the consumption after the that including the higher abrasions, it will show that 109. So the difference between both is very high, between 58 micron for abrasion free and the 109. That was the total higher abrasions. In my machine, Schwint, I'm using Schwint, and Schwint have the ability to treat whole higher abrasions and selectively can be select the clinically significant part of the higher abrasions that we need to treat. If we will treat them all, then we will end up with the consumptions of a difference from the low order abrasions or abrasion free around 40 microns. And in this situation, we need to adjust as much as possible in a way that to prevent hyperopic shift, because here, if we will go through in this way, we will go through to hyperopic shift. So that's the way that we are starting in Schwinn. We have the ability to select. So we select the clinically significant part, and then we went through. We try to adjust the consumption of tissue in a way that it will be near to the abrasion free, with a difference that equal to the effect of the spherical abrasion on the center of the cornea. So I'm keeping around difference around 6 microns between the abrasion free and the abrasion, but not in this case. Because if you will go to this case and we will do it in that way, keeping a difference of 6 micron or 10 micron, we will end up with high undercorrection around -3. So what I did is that I went through and I adjust the higher derivations in a way that it reduced to 103 instead of 106. And the difference, the second goal is that to keep the difference between central and peripheral not more than 20 micron. But even so, it's not in this case, because if we will try to adjust the periphery and the center, because any difference more than 10 micron between the center and the periphery, we will have under correction in myopia if the periphery is more than the center in 10. And in reverse, if the center is more than the periphery and more than 10, we will have hyperopic shift. So we can control our work when we are, and we know the result from what we are seeing through our plan. If we will go to the third, we can see that we implant the low order abrasions in plus 1.5 minus 0.2524 in a way that the difference in between the center and the periphery, it start to be less than 15 micron. So we know that the patient will end up with around minus 0.5, but through which we could treat all the high order abrasions. And that's what's done. So that's the ablation profile. Definitely, I got only one example for the right eye, and this is the ablation profile through which we can see that we treat around 1.3 comma and trefoil 0.04 and spherical abrasion of 2.5 with optical zone around 7 millimeter with a low order abrasions of plus 1.5, 0.25, minus 0.25 for cylinder. That corneal map clearly shows what's the difference between, for the right eye, the pre-op and post-op. On the left side, the pre-op, and on the right side, the post-op. This is the high order abrasions of the right eye and shows clearly the difference between 2.1 and 1.14. So preoperatively it was 2.1 and postoperatively reduced to 1.14. Here the total RMS. I will show you here. This is the value of the total high order abrasions, and this is the value of post-op total high order abrasion for the right eye. That's the epithelial map. The important things that we did, because this patient had an abnormal epithelial thickness in the central part. You can see in the central part, the epithelial thickness was 87 micron. You can imagine 87 micron compared to 56 micron in the left eye. So difference between them pre-op and post-op, that right eye and in the left eye. If we will go to the left eye, again, the difference was clearly between the tangential anterior. I'm using tangential map instead of sagittal. The tangential anterior showed the flattening in the center, and tangential anterior, and on the right side, it shows how it's regularized. Same issues for the high order abrasions, and same issues for the epithelial map. Now, in the epithelial map for the left, it was 96 micron in the center, and start to be 56 micron after the regularization, because the epithelial cells start to manipulate and remodel all the elevation. So it's regularized after it was irregular in an unusual way. Now, again, to the result. If we return back to the refraction post-op, and that's the important things, that one of the target for me, it was from plus 0.75 to minus 0.5. And that was one of the challenging to keep this patient within the plus minus 1 for the right eye. If we will go to the left eye, you'll see that it's minus 0.75. And when I finish this strategy, I know that this patient will end up with plus minus 0.75, because the difference between the periphery and the center was more than 15. If the difference between the periphery and the center was less than 10 micron, I could say that this patient could end up with a neutral or emmetropic. But because the difference was more than 10, so I could expect that the patient will end up with a little bit myopic shift because the periphery was more than the central. If we will go back to the high order patients treatment, it was from the total of 2.1 to 1.4 and 2.116 to 1. The visual acuity enhanced from the from aided 0.6 to 1 and from aided 0.4 to 1. The near vision from N6, no correction, without correction, to N3 and in both eyes. I think that this result, it need a special planning and it need a special machine that can deal with these cases. That's my presentation, and great thanks. And this is the eye after the surgery.
Thank you very much, Dr.
Mohammed. I think that I'm on the time.
Safwan, even you have still 5 minutes. Thank you very much.
Great, thanks for you, my dear.
Question, Safwan. Okay, so
Yes.
you did trans-PRK or you did flap here, this patient?
Sure, I said in the beginning, Osama,
Yeah.
there is no LASIK or flap for those patients. It's a trans-PRK.
But the problem, because your epithelium is too thick, did you compensate? Because Schwind will take a fixed amount of epithelium, so it doesn't look to your epithelium map by Schwind laser.
Yeah.
So how you compensate for that?
Yeah, the compensation for that is very easy. First of all, and because here you pushed me to go to the details of the technology.
Sorry for that.
See, if you are pushing me, I would say that, well, I will not go through a technical issues, because once I will go to the technical issues, Ashraf will say that, well, Safwan, we don't have, we are not using Schwind, so how we will deal with it? So now you are pushing me, so I will go through and I will say, yes, you are right.
2 minutes, okay.
How we could deal with the 89 or 87 or 96, because our epithelial or trans-PRK is adjustable, Osama. So you can adjust it. You can adjust and you can put whatever you need. You need in the center to treat 100 micron. And in the periphery, you need to treat 110 or 65. So it is adjustable. So that's why I adjust the epithelial map with the trans-epithelial planning to be adjusted on those patients, for those patients. Yes.
So you did a topo guide trans PRK using Schwind.
Yes, exactly.
How do you choose the type of high order abrasion? You choose the some of the coma, and you left the spherical abrasion.
My dear.
Yes.
No, it's not this way.
You treat
See, I
some
will go back.
You treat some of the coma, and you left the spherical abrasion to increase.
The issues is that, first of all, I need to highlight the clinically significant part. That first, that's very important. So that's my target. The clinically significant, it appear here in this pyramid, and it shows clearly in colors that we have around 4 in spherical abrasion. We have around, this is a spherical equivalent. So if you will put your arrows on it, it will shows that it's around 1.7 or 1.8. So those my target. Spherical abrasion and coma. I don't differentiate between them. I have to treat them because they are my target. How I'm compensate in the low order abrasion. Means that I'm compensate in the refractive error, but I'm keeping the clinically significant high order abrasions kept as it. I need to treat them. So when I'm treating them, I will go back. I have, for example, a consumption, definitely those highly aberrated cornea. So when in highly aberrated cornea, you are not targeting a refractive outcome as a low order abrasion. But you don't need to shift yourself in hyperopic, or you don't need to shift yourself in -3 or -4. So you need to keep yourself in within ±1. That's the aim of what I'm saying. Otherwise, you can easily go through and treat the refractive error that the patient have and treat the whole high order patients. And it's very simply that you will end up with a hyperopic shift. Because
in RK patients, what zone, how you select your optical zone?
The higher that you can, means that.
I mean, it depends on how central the RKs are to the center of the cornea?
No.
It's not related.
Does not differ.
Not related. The wider the optical zone, the more the regularized the cornea that you have. Usually in RK, they have a good pachymetry. So they have a 530 or 540. So it doesn't matter that what's the optical zone that you are going to treat. Now, someone will say, well, you can treat only high order abrasions, leave the low order abrasions. It's not the true, because if you will treat only high order abrasions, you are treating here mainly spherical abrasion, and those patients having a mixed astigmatism, plus minus. So you will end up, instead of plus 1.5, you will end up with a plus 3.75 or plus 4. So it's a mixed, and it's a challenging, but you need to know a very important issues is that here we need to have a difference between the center and periphery, not more than 15 up to 20, in a way that you will end up with the periphery more than the central. So you will end up with within minus plus 1. But I prefer minus 1. That's what I did it. So that's why you can see my profile. If I will elongate my profile, the important point, if you will go to the ablation depth, you will see that the central part is 109 micron, and the peripheral part is 126 micron on an optical zone of 7 millimeter. And the difference between them is around 15 to 16 micron. So this patient will end up with around minus 0.5 to minus 0.75. Maximally, he will not exceed minus 1. So this is the strategy. And if you will go through the refractive error here that mentioned in manifest refractive error is the refractive error of the patient. That we manipulate the astigmatism in a way that the central area start to be a little bit higher than what it was before. So we reduce the difference between the center and the periphery.
I think it's very crucial to have the epithelial mapping for such cases. And it's also better to do trans-PRK, because if you remove the epithelium manually, all the number you had will be completely wrong for the treatment.
So Osama, you can enjoy this epithelial map and how it's nice. I think that let me give you another one. The another one is much more beauty because I think that we are not seeing such an epithelial map. 96, I'm using MS39, 96 micron in the center compared to the 56 micron after the treatment. So you can imagine what was how the thickness of the epithelial map. And this patient had an experience of chalazion, and when she had the chalazion, the cyst affect the epithelial distribution in the center of the cornea. So she came directly saying that before the treatment, saying that I start not seeing well after the chalazion, and she is saying the truth. Because if you will see the epithelial map, you can see that the thickness of 95 is unusual. This is just to remodel the depth of the center of the cornea, because the center of the cornea is very flat.
So, can we have another opinion of Dr. Nancy and Dr. Ashraf? Suppose they don't have the facility to have Schwind MRs, as Dr. Safwan mentioned. So what you are going to do? This is what we need to learn. I mean,
you can have the other one.
I used Schwind from 2008 till 2012. Then I stopped. Why? Because I changed the place. And since this time, I am on Alcon machine till now. But I really enjoy Schwind and the surface ablation and how we can treat the abrasions through Schwind. It's really a fantastic and really a great machine. This is my opinion.
You can use now the wave light, because now wave light presenting transepithelial, as I told you. So transepithelial with topo guided, you can use them.
Yes.
But
Nancy?
Yeah, actually, I've enjoyed your talk, Dr. Safwan. I've had to manage a few patients with RK, but not with surface ablation. I had to do some cataract surgery on them, and they were operated on by Professor Fedorov like 20 years ago. And I do agree with your approach to trans surface ablation. It's just, I think I would go your way of treating them. So I don't have anything to add. I think Dr. Safwan just managed them the way I would do. But they are difficult, and you cannot sometimes, you cannot guess or guarantee how the cornea behaves in these patients. You think even they are constructed in a very regular way, these RK wounds just sometimes might surprise you. And I've got that with some patients. Luckily, I did not have to do the laser ablation, but especially when you go inside the eye, they just, they act differently. So thank you very much, Dr. Safwan. I've enjoyed this way, and that I think is the best way to approach them.
I think that you highlight something very important when you are doing cataract for those patients. I think that when you are doing the main incision, one of the RK will open. So it will challenge you in an unusual way, because you cannot close it. And I have one case that I did cataract, I think that 2008. So I sutured it.
Yeah, I sutured them. Yeah,
I sutured the main incision, and I sutured the base of it.
Yes, I had to suture them, actually, yeah.
Can I add some highlights for RK, because I did some of the RKs, yes. My recommendation in these cases, when you do the wounds, usually as periphery as you can, even limbal.
Yes.
And if you can open a little bit limbal incision for the keratome, or in between the RKs,
in between
the IA, it will be better.
Yes.
And also when using the IOL, as much as you can use a zero spherical ablation. If you didn't have the ICR, which is the most I think the most perfect lens for the post-operatively. So when using a spherical abrasion zero, it is the best, and always suspect hypermetropic shift in the first 3 to 4 weeks. Post-operatively, and sometimes it resolves spontaneously. This is normally in these RKs.
There's a comment from Dr. Marwan, I think, just disappearing. He do pupilloplasty. The other option is pinhole IOL. It's very good if someone had very high regularity. And then we do cataract. Pinhole option, IOL is very good for vision.
Yes, we don't have in Egypt, not yet the pinhole, but I think this is the best IOL you can put it in RKs.
Yes. I think that you are true. If they have a cataract and you don't have the facility to regularize the cornea, then one of the best option is to put the pinhole IOL in those patients, and they are doing well.
Thank you very much, Dr. Osama. Yes, please.
And just you did mention Safwan, I'm sure you do it. Always this case, you need mitomycin C and maybe longer duration than other.
Yeah. That's absolutely right. That's one of the technical issues that we are doing it regularly for all trans PRK. We are using the cold water after the laser, and we are using the mitomycin C.
Thank you much, everyone. Dr. Mohammed, any last comment?
Thank you very much, Dr. Osama. Thank you, Dr. Safwan. Thanks a lot, Dr. Ashraf and Dr. Nancy. Nice to have you all with us. In the last session of 2020 MIOM, Middle East Ophthalmology meetings. And I would like, before we end this session, that was very interesting. We have 2 sessions, posterior and anterior. And I enjoy anterior and posterior session, even though anterior it's difficult a little bit for me, but I enjoy a little bit, because I'm not
a little bit sleepy.
Refractive. But I would like to invite you all to Al-Qasimi 6th edition quick Qasimi Ophthalmology International Conference. That will be in February from 11 to 14. It will be 2 days hybrid, 11 and 12. That means physical and virtual at the same time. And we will have 2 virtual on 13 and 14. And we are having many things about this one. We have many
Muhammad, you're not hearing you continuously.
Dr. Muhammad, your signal is.
Dr. Muhammad, your computer is fading down.
Anyway, Dr. Salma, you can.
I think he wishing us a very good evening, everyone, and looking forward for the quick, which is I'm sure it will be interesting 4 days meeting. So it will be mixed, as he said, hybrid. So today's real, and the other one is it's a webinar system, and I'm sure it will be a very successful meeting. I look forward.
Okay, you can hear me now, Osama?
Now
okay,
we can, yes, we can hear you. Yes, now.
I don't know, maybe Asafan, he just read on me, maybe something that I cannot talk, you know, sometimes he try to do something. Anyway, thank you. Thank you very much for all of you. And we hope to see you, inshallah, in the next year with MIOM activities, inshallah. Thanks for all our here speakers.
Happy New Year, everyone.
Thank you very much. Happy New Year, everyone. And Merry Christmas also. Thank you very much. Take care. Bye-bye. Take care. Bye-bye.